Chapter 19, Part 1, Cardiac Anatomy, Screencast 3. Now, this is something that is from the previous screencast that I wanted to finish up, but I thought it was important to address separately because it is kind of tied into function of the heart. And what this slide here is addressing is the arrangement of cardiac tissue in a spiral way. When we look, once again, when we talked about the fibroskeleton, we know that the cells, the muscle cells, are attached to the skeleton, but they're arranged in a certain way. And how they are arranged is in spiral bundles. Now, keep in mind what muscle does, it contracts. So let's kind of think about how this arrangement is so important. The atrial contraction moves the walls inward. So what that is going to do, it basically narrows the heart and it's going to maximize ventricular filling. And that's important. When we look at how the ventricles are contracting, let's think of it how we wring a mop. And when you wring a mop, the point is to kind of squeeze as much water out of that mop as possible. And it makes sense that we want that type of action in the ventricles because we want good ventricular emptying. So that is what we see. And basically, the contraction starts at the apex, and then we're just kind of squeezing upwards. And that is ideal to make sure blood will be exiting the ventricles overall. Now, the next part of the screencast is focusing on the supply of the heart itself, and that is the coronary vessels. And remember, the heart cannot access the blood that's moving through it. So it has its own circulation system. It has coronary arteries and coronary veins. And once again, the arteries are going to be transporting oxygenated blood to the wall of the heart, and the veins are going to be taking deoxygenated blood back from the heart wall and towards the right heart so it can become reoxygenated. Now, there are two primary coronary arteries, the right coronary artery and the left coronary artery, and they are branching off of the aorta. The branches of the right coronary artery are the right marginal artery, that is supplying the right heart border. If we look at the posterior interventricular artery, keep that terminology in mind, it's the posterior or the backside of the heart and both of the ventricles. The left coronary artery has two branches. They are the circumflex artery. That is responsible for making sure blood is getting to the left atrium and the ventricle. And then we have the big daddy of all coronary arteries, and that is the anterior interventricular artery. This supplies the anterior surface of the ventricles and most of the interventricular septum. So this is a vessel in particular, if it is blocked or has blockages, quite often will have a fatal effect in creating a fatal heart attack. So really is one of the major vessels that we see. When looking at this view, we can actually see the coronary arteries, but what I want to point out here, when you look at this diagram in your textbook or on the slides, notice the different shades of red. And what they are trying to do here is identify both anterior and posterior vessels and their relationship in a single diagram. The darker red, those are going to be the vessels that we see on the anterior surface. So we see the right coronary artery, we see the left coronary artery, and the anterior branches. We can see the beginning of the circumflex artery and the anterior interventricular artery. And when we look on the right side, we can basically see the marginal artery. On the back, that is where we're actually going to see the posterior interventricular artery. Now, these arteries are different than other arteries within the body, and they're quite often classified as functional end arteries. So there are anastomoses, and these are basically branches. And what happens basically, if we have the blockage of a coronary artery, we're not going to have enough flow to the wall of the heart. So what's happened here, these arterial anastomoses, they're connecting vessels, allowing blood to arrive to areas of the heart by more than one route. Generally, they're not going to be fully functional and effective alternates, but it's the body trying to compensate for blockages. Now, another thing to keep in mind based on the position of the coronary arteries, and remember, they're located within sulci. And what's characteristic of the vessels here, the flow is intermittent based on heart contractions. So when the heart is relaxed, the vessels will be open and blood will flow freely through these vessels. When the heart is contracting, these vessels are going to be compressed, and that is going to interrupt the flow. Now, here we actually are looking at the veins, and this is also what they're trying to do using anterior and posterior views. And when we look at the largest of the veins, it is the great cardiac vein, and it is going to sit right next to the anterior interventricular artery. If we look at the middle cardiac vein, that is actually on the back. We're going to have these smaller cardiac veins, which appear next to the marginal artery. But then we have the coronary sinus. This is a very predominant structure on the posterior of the heart. And basically, this is receiving blood from the cardiac veins and returning that blood to the right atrium. Now, when we look at heart disease, and heart disease can be considered coronary heart disease, angina pectoris, and myocardial infarct. When we talk about heart disease, we're specifically talking about blockages that we find within the coronary arteries. Cardiovascular disease is a broader term which applies to other vessels, including the heart, but heart disease gets its own term for the most part. And the process that we see is atherosclerosis. And what this is actually the buildup of plaque in the coronary arteries. So because you have a narrowing of the vessels, you're reducing flow to the heart muscle, and you're also creating additional resistance. Now, coronary spasm, this is a sudden narrowing of the vessels. And this is something that we see more often in women when they present with a heart attack, and it is much more intermittent. But keep in mind, both of these conditions, either atherosclerosis or a spasm, can result in either a myocardial infarct, a heart attack, or angina, which is chest pain. Now, angina pectoris, once again, is chest pain, and it's usually felt during strenuous activity. This is one of the reasons why when they are testing for heart disease, they will use a stress test. They will actually use exercise to see if the heart is capable of meeting the demand of the exercise. It's rather characteristic, and generally it's felt on the left side of the chest, the left arm, or jaw. Typically, what someone will take is nitroglycerin, and this is a very fast-acting vasodilator, which will basically vasodilate the coronary arteries and increase blood flow to these areas. A heart attack, and the clinical term is a myocardial infarct. This is due to complete and sudden occlusion of a coronary artery. During this period of time, the myocardium is deprived of oxygen and potentially could result in death of the tissue. Generally, the symptoms here are significant excruciating chest pain, and it radiates down the left arm. Other symptoms that are associated with a heart attack are weakness, shortness of breath, nausea, anxiety, and sweating. Now, a couple of things that we want to keep in mind here, and this is going back to the microscopic structure of cardiac muscle. Another thing that I've put a major emphasis on here is the fact that cardiac muscle is striated as is skeletal muscle. This means that the architecture or the basic functional unit of cardiac muscle is the sarcomere. So now, everything that you learned about skeletal muscle with respect to fourth generation is going to carry over to cardiac muscle because they share the same architecture. Now, when we look at cardiac muscle, one of the major differences is the cells are much shorter and they're branched. Typically, we're going to see nuclei that are going to be more centrally located as opposed to pushed to the periphery or the sarcolemma, which we saw in skeletal muscle. We're going to see a relatively consistent connective tissue, endomysium, okay? The sarcolemma, so there's a plasma membrane. Sarcoplasmic reticulum, typically going to be a calcium warehouse. But keep in mind here, we're going to be looking at the myofilaments once again arranged in sarcomeres. So this is what is shared with skeletal muscle, that same architecture. And so a couple things to keep in mind is the branching nature. We'll kind of talk about why that's important. And if the fibers are branching, let's think about this. Okay, so they're going to generate force from multiple directions, and this is going to aid in more effective or efficient ventricular emptying. Remember, force in muscle is generated along the length of the fibers. If the fibers are branching in different directions, we're going to see that force dissipated in different directions and much more efficient emptying of the ventricles when they contract. Now, if we look at some of the intracellular structures, once again, we have the sarcolemma. It's folded, okay? This adds to the stability of the myocardium. It's also going to allow for better communication between cells. Now, a very important connection is the intercalated disc. And this is probably something that you use to distinguish cardiac muscle from skeletal muscle in the histology component of AMP1. Two structures that we're going to find within the intercalated disc are desmosomes and gap junctions. So let's take a look at them. Now, here, there's two things, once again, that make up that intercalated disc. And they're intracellular connections, which were addressed in AMP1. But keep in mind, okay, we have gap junctions. So gap junctions are these protein channels, and they are going to allow for the flow of ions. So think of this as an electrical connection, and this is going to allow in the coordinated movement of the heart itself as the electrical signal is moving from cell to cell. When we talk about desmosomes, there's two general functions here. I like to think of desmosomes as cellular Velcro that's actually connecting two cells. But this is a special type connection because remember, when we look at the branching cells of the heart, when they contract, there could be a tendency for those cells to pull away from each other. Desmosomes are going to keep that intact. The other thing that they are going to do is help transmit the force from the contractile effort of the heart itself. Now here we can basically see the general architecture of cardiac muscle cell. Here it has the exact same architecture that you learned about skeletal muscle. And once again, differences would be that the fibers are shorter, they're branching, and also how they're connected at the intercalated disc. Now, when we look at how the muscle and the requirement of energy for cardiac muscle, it is highly metabolic, indicating that there is a very, very high demand for energy. This is supported by the fact that there is an extensive blood supply and lots of mitochondria. There's also going to be a couple of proteins, in particular myoglobin, which will be responsible for oxygen transport within the myocardium, and then creatine kinase. Now, what's very characteristic of the heart that differentiates it from other structures is the fact that it really doesn't care what its energy source is. It will use anything. So it can use glucose, it can use lactic acid, ketone bodies, fatty acids, all of these in an effort to generate ATP. But keep in mind that generally we're looking at aerobic metabolism. And so this becomes an issue because there may be ischemia, okay, when oxygen is low. And once again, we already addressed the fact that if there is an interference of blood flow to the heart muscle, this can cause cell death or an infarct.